Three, two, one. We are live now.
Good evening to all of you. On behalf of Mastro Biologicals, I extend a warm welcome to all the faculty and the panelists for today's webinar. Dr. Ram sir, Dr. Manoj sir, Ajaz Kariem sir, Dr. Bharat Dave sir, Krishna Subramanyam sir, and Dr. Amrithlal Mascarenhas sir will be joining us as well. On the outset, I wish you all a very happy Independence Day to all of us. 77th Independence Day of Republic of India. It's a proud moment for all of us, and this day is very, very special. And we feel very, very proud to call all of us as Indians in today. On the contrary, almost is estimated that 50 million of Indian population is affected with osteoporosis. So we couldn't have a better theme or a topic to conduct a freedom webinar today on the eve of Independence Day. And we have aptly kept the theme as strong bones, healthier nation. And Mastro Biologicals are your trusted partners in helping you build a strong bones and a healthier nation, and committed, you being the strong master of bone health. I'm sure you need partners in terms of building up a very strong osteoporosis management for your patients. So we have today's webinar in two parts. First, we would have a talk by Dr. Ram sir on importance of patient counseling and osteoporosis, followed by a panel discussion on DENOSUMAB, when, where, and how long, which would be moderated by Dr. Manoj Chadha sir. And the faculties are Dr. Bharat Dave sir, Dr. Ajaz Kariem sir, Dr. Krishna Subramanyam sir, and Dr. Amrithlal Mascarenhas sir. With this, I would not short introduction. I would like to hand over this for further proceedings to Dr. Humail, who would introduce Dr. Ram Chaddha sir to the viewers. And I extend all a warm welcome to all the viewers who have logged in for this freedom webinar. Thank you. And Dr. Humail.
Yeah, so good evening to everyone, and a warm welcome to everyone present on behalf of Mastro Biologicals for this webinar. It's a great pleasure for me to introduce our speaker for the day, Dr. Ram Chaddha sir, who is going to talk to us about the importance of patient counseling in osteoporosis. Dr. Ram Chaddha is a prominent orthopedic surgeon who specializes in spine surgery with an extensive exposure and experience in complex spine instrumentation procedures, including deformities and revision surgeries. Dr. Ram Chaddha is a consultant spine surgeon at Leelavati Hospital and Apollo Hospital, Mumbai, and is considered as one of the best orthopedic spine surgeons in Mumbai. He is actually pioneered in minimally invasive cosmetic spine surgeries in India. In addition to practicing as a spine surgeon, he has also been actively associated with academics and teaching. Dr. Ram Chaddha has a number of academic papers to his credit that he has presented at the regional, national, and international conferences. Alongside that, Dr. Ram Chaddha is also the president-elect of Indian Orthopaedic Association. So it's an honor and a privilege to welcome Dr. Ram Chaddha on behalf of Mastro Biologicals for this webinar.
Thank you, Dr. Humail, and over to Ram sir.
Good evening, everybody. At the outset, thank you, Javed. Thank you, Humail. Thank you, Mastro Biologicals. It's a pleasure to be here. My dear friends, Dr. Manoj Chadha, Dr. Amrithlal Mascarenhas, Dr. Bharat Dave, Dr. Krishna Subramanyam, and Dr. Ajaz Kariem, all of whom are here in attendance on Independence Day. And we're going to be talking about something which is the essence of independence, which is interdependence. We all know that independence keeps us free. However, it is interdependence, which is the essence of existence, and it is based on cooperation, collaboration, and coexistence. I'm here sharing what I have learned from my patients over the past 2.5 decades, since I aggressively had modes to treat the silent killer, osteoporosis. I was practicing aggressive orthopedics before that, And we didn't pay much heed to this very silent, looming large adversary, which we only realized about 2.5 decades back. Today, we have patients who come to us with what they want, and we try to provide them what they need. What I've learned most for living in the same home with my mother. She completed 100 years of age on the 3rd of March, 2023. I was most privileged and honored to be there. And it was something which made me look within, introspect. And there was intuition rather than tuition coming from the outside, which made me think, is it that we are providing the elderly what they want? Should we just stop with the bare necessity of what they need? Or do we need to go a little bit beyond and give them something in between their wants and needs, which is ideally what they deserve? And why do they deserve this? Because as they grow older, rather than adding years to life, they should add life to the years that they are spending on this planet. I go back to what makes a good life. It's the longest study on happiness by Robert Waldinger. And in this, 268 Harvard sophomores since 1938, 40 of whom are still alive, were asked what keeps them going, what keeps them happy, healthy, and their longevity. And what came out was close, meaningful relationships, more than money or fame, keeps people happy throughout their lives. Are we, as clinicians, contributing to those close, meaningful relationships? Or are we just prescribing sunlight, dairy products, exercise, pills, some amount of vegetarian and non-vegetarian foodstuffs, and calling it a day? We need to think and make not just the patient, but our own brethren aware of where we are heading. We need to first understand the gravity of the problem ourselves and convey it, percolate it to society in general. We've realized that 1 out of 2 adults have osteopenia, 1 out of 5 have osteoporosis, more prevalent in women. 1 out of 3 women in postmenopausal age group have osteoporosis. And it is pan-India. This was a study which looked at north, south, east, and west. But pan-India, we have people suffering beyond what most of the world is. Yet another thing in our country. We have women menopausing earlier and living longer. Hence, it increases the risk of osteoporosis and heart attack in the Indian postmenopausal woman. And of course, internationally, we know worldwide that there are more than 8.9 million fractures every year. Every 3 seconds, there's an osteoporotic fracture. More than 200 million women worldwide have osteoporosis. 1/10 of women aged 60, 1/5 of women aged 70, 2/5 of women aged 80, and 2/3 of women above 90. And I am with a 100-year-old seated next to me today. Hence, we have to keep them far away from this unfortunate, life-changing event, which may be a fragility fracture. This is the global problem every 3 seconds, and we have to be aware of it. Besides this, since I deal mainly with spine, we've realized that 1/3 of vertebral fractures seem to be missed. And unfortunately, it's something that comes to light very, very late. These are 2019 global health studies. Low bone mineral density related fractures. India is in the top bracket of 50,000 to 100,000. Disability adjusted life years. Again, India is in the top bracket. Hence, all these disabilities, quality of life issues have to be understood by us so that we can convey it to our patients when they do come to us for advice. What do we want to achieve when we communicate with our patients? We all have these elderly coming with caregivers who are usually family members in our country, second generation or immediate next generation, daughter or daughter-in-law most commonly. And they come with them with the monkey on the back of perils of the past and fear of the future. It's our duty to share with them pragmatism of the present. They all come with fears, fear of the unknown. They are all aware there are impermanence. There's death looming large, but it is false evidence appearing real. It's our duty to share the real fear and allay the perceived fear. It's only when we take care of this perceived fear that the grief, which otherwise they would jump from denial to anger to bargaining, can actually go from denial to acceptance, as mentioned by Elizabeth Kubler-Ross. We have to handhold the elderly, move them from denial when they don't agree that they have a fragility, fracture, or osteoporosis, to anger as to why did they get it? They've been eating so well all their lives. Then they sort of bargain with you. Can't we just have some calcium or milk and feel better? Finally, they get very depressed about the whole thing and do agree, if you spend time enough with them, to accept, comply, and adhere to the treatment, which you need to discuss with them on day one. We need to have happy elderly community who are looking forward to a hope, to a good life. And how can we do that? We have to have motivational interviewing skills. Every time we see the elderly, look in their eyes. Don't just look, but see. Don't just hear them, listen to them. Don't just touch them. Let them feel you and you feel them. Please understand, we are not here to pity or sympathize with them. We have to share the empathy and compassion which comes from deep within. It's not just contacting them or doing yoga job, but connecting with them and establishing a sanjog. Gentlemen, we are doing our duty as we've always done as a part of the noble profession. But here, we have to go beyond that and offer some selfless service in the form of time and do some karma. It's then and only then that a 100-year-old could someday become a 102-year-old and still be happy and smiling. Who are the two set of stakeholders besides yourself in this action plan? There are two sets of people, the nurse practitioner or your personal assistant or your team on one side, and the immediate caregiver, the care provider. I don't like calling them caretakers. So that's the nurse physician or the physician attendant who's relatively out of focus and trying to explain to the immediate caregiver the way forward. And how is this to be done? There are 4 steps: education, compliance, adherence, and counseling. Education we are all aware of, but in brief, we need to tell them what a DEXA actually tells us. Where is the quality of bone affected and what exactly is happening? If we do use the FRAX, make them aware, show them the predictability as to how an Indian FRAX can tell you where you would be at the end of 10 years. Also tell them the difference between things that you can change and those that you need to accept. So the non-modifiable and the modifiable. What should they eat? What should they give up? What should they do as a part of their dinacharya or their daily routine? Let them know all the things which we've learned from our fracks in simple language. Ask them whether they have a bump in their back now, whether they've lost height, whether their clothes have actually become longer than they ought to be. Are they getting occasional falls? Do they have certain diseases that they've noticed? All these and more. Advise them the way forward. Use bone models, use aids, use audiovisual, use theater, drama, whatever you want, so that you can convince them about the need for calcium, vitamin D, reducing alcohol and increasing exercise, giving up smoking. And if you've done that, then comes the stage to talk them through the medical line. It's not just calcium and vitamin D3 that I do with even a 25 or a 30-year-old lady, but a postmenopausal regular DEXA. If they have seen somebody and are on HRT and SERM, let them continue or then shift them to something that you may control. Initiate bisphosphonates in the early stage if they are treatment naive or they have just got osteopenia going to osteoporosis. But yes, once established, then you need to swap and go to either teriparatide or denosumab, depending on what is really needed and the dose and the way it should be done. Today, we have large number of available options, from the oral alendronate to the parenteral once-a-year zoledronic acid, to the 6-monthly monoclonal antibody denosumab, to the only anabolic in India available as yet, teriparatide, and looming large, the other monoclonal antibody and the other anabolic, romosozumab and abaloparatide. Yes, we would have them sooner, if not later. So we are in the present, but we are looking at a future coming soon. The future today, for 10 years longevity-wise, seems to be denosumab, which we know is there. Teriparatide is there for 2 years, may get increased over a period of time, especially in India, as compared to what it is already in other parts of the world. And finally, counseling. I always say there are 3 steps to counseling: counseling, counseling, and counseling. This is the most important. And why is that so? Because unfortunately, we have this huge dichotomy in medical practice. Our diagnosis is built on suspicion, doubt, skepticism. We do so many investigations like the police or the CID. And what is our treatment based on? It's supposed to be based on the other end of the spectrum, which is faith, belief, trust. How can we have suspicion and faith working together? For this, we need essential communication skills. You have to be open and frank with the patient. It's an art which develops over the entire medical career. It's a lifelong pursuit. Every patient teaches you this. All of us do not have equal talent, but all of us have an equal opportunity to develop our talents. Advice and counseling are the 2 most important and go far beyond pharmacological treatment. This is critical. Mental health consultations for the elderly, especially post-COVID, are essential and a prerequisite to any form of treatment. We should understand all of them come with an element of depression and anxiety, and they need to be sorted. 9 components. Listen to the patient, respect their views, have open communications about all treatment preferences, discuss all management options, allow them to ask as many questions, ensure that they've understood, be aware of their language, accept the cultural influences, and compensate using your skills in communication. You are neither above them nor below them. You are besides them. And that's the way that you ought to be. Use non-verbal forms of communication. It's a shared understanding, an attentive posture, have an eye-to-eye contact, active listening, nodding. Let them tell their story. Have short, open-ended questions. And go by what Mehrabian said, the 7-38-55% rule. 7% is the spoken word, 38% is the voice, the tonality, and 55% is the body language. So it's 7% verbal, 38% vocal, and 55% visual. Give them the time. And I repeat, don't just look, but see. Don't just hear, but listen. Don't just touch, but feel. Get out of your head into your heart, and only then move your hands. Don't show pity, show compassion. Not sympathy, it has to be empathy. We have to be wearing their shoes and be very truthful and transparent in whatever you're conveying. That builds trust. Please remember this one line. It's very, very personal and important to me. Don't practice for income, but for outcome. Time that we move from knowledge to wisdom, from selfishness to selflessness to altruism for the larger good. Don't just share information. Try to reform and transform the quality of life of the person in front of you, especially the elderly. Move from doing your duty or your kriya to finding your calling through karma. Move from contact to connection, yoga jog to sanjog. Let's move and do something which will not just treat, but heal. You have one opportunity. The mission of your life should be to leave a better world behind what you had inherited. So, my dear friends, let's put our hands together on Independence Day and promise that we shall be interdependent and help our patients move ahead and coexist with good quality of life. Thank you all for a very, very patient hearing.
Thank you so much, Ram sir, for that heart-touching presentation on patient counseling. Though every slide had a lot of take-home points, but what I gather is one point which can probably sum it up is truth, transparency, always build trust. Thank you so much for that wonderful presentation, sir. And it is indeed a pleasure, an honor, and a privilege to have you today as a part of Freedom Webinar, sir. Thank you very much, sir. Moving on for our next part of the program, which is a panel discussion on DENOSUMAB, when, where, and how long. Let me have that pleasure and privilege and honor of introducing our moderator to you today. Dr. Manoj Chadha, sir, is a well-known personality in the field of endocrinology, in the field of osteoporosis, and has been esteemed as a national faculty. For those who know not much about him, but then he is a consultant endocrinologist at PD Hinduja Hospital, Mumbai, and Hope and Care Center at Navi Mumbai. He has a vast teaching experience with DNB endocrinology as a teacher since 2008. Ex-faculty in endocrine department at KEM and Nair Hospital, Mumbai. He's been trained in use of artificial pancreas biostarter at University of Ulm at Germany. He's been the past president of Endocrine Society of India from 17 to 18, past president of ISBMR, Indian Society for Bone and Mineral Research for 4 years, 2015 to 19, and a member of Asia Pacific Regional Committee of International Osteoporosis Foundation. I'm sure it's our honor to have him as a moderator today for this particular session on DENOSUMAB. Over to Manoj, sir. Thank you very much, sir, for joining in.
Thank you, Javed. And my compliments to Ram. It was wonderful, right from the heart. I mean, I've always known that Ram is a person with the heart and the brain at the right places. And I think today he has convinced even those who didn't believe in him. Thank you, Ram. So we get on with the panel discussion. I was told we have about 45 minutes for this discussion. And since the tone has been set for the problem that is there in front of us, all of us are looking at it at different times of our lives and the patient's lives. And we're trying to do the best possible for them. And what we learned in school and college that prevention is always better than cure. And probably osteoporosis is one such disorder, which tells us that it really works well. Treatment, we have a lot of modalities, which is what we're going to discuss. I will introduce my 4 hosts, panelists, and I'm going to just present certain garden variety cases so that I think most of our delegates are there with us on the same page and they say, oh yes, I have seen this case recently. And then if time permits, we can take up some rare things which at least everyone should be aware of, and then they can refer it to a higher center if need be. So in no specific order, Dr. Ajaz Karim Khan is a rheumatologist from Srinagar and a visiting faculty at the Max Hospital, Delhi, and the KIMS, Hyderabad. He's been trained at the NIMS, Hyderabad, and worked as a teaching faculty in CMC, Vellore, and NIMS. We have Dr. Amrithlal Mascarenhas, who's a reputable spine surgeon from Manipal Hospital, Bangalore, with more than 21 years of experience. He's received his FNB surgery in Spinal Injury Center, Delhi, and specializes in complex spine disorders and trauma. Dr. Krishna Subramanyam, he's a lead orthopedic surgeon at the Yashoda Hospital, Hyderabad. And the main field of interest is arthroplasty, arthroscopy, geriatric orthopedic, and osteoporosis. He's been the recipient of Innovative Orthopedic Surgeons of India Award from Times of India in 2022. And last but not the least, Dr. Bharat Dave from Ahmedabad is the founder, director of Stavya Spine Hospital. He's a renowned spine surgeon with special interest in osteoporosis. He's been the past president of the Association of Spine Surgeons of India. So welcome, friends. What I'm going to do, maybe take one name for discussing the case. We'll ask 2-3 questions, and then it's open for the other 3 to also put in a comment. My only request would be to keep it short and sweet so that we can take up more cases for discussion. Let's begin with, I think, Dr. Subramaniam can take the first. Where are my questions that I had prepared for you all? Yeah. So we'll start with a very simple, says 65-year-old lady who's come for a routine, nowadays what we have health checkup program. And she's been otherwise doing well, just had 3 pregnancies during her early part of life, has been fairly active. And now when they've done a bone density, they find that she has a T-score of -2.9 at the lumbar spine, and at the femoral neck, it's -2.1. So maybe Dr. Subramaniam can start that. How would you like to approach this patient? And then since the focus is on treatment right now, no we're trying to undermine the other points that Ram had raised regarding the, the causes of low bone density and low bone mass, and what are the factors like smoking, lack of exercise, sarcopenia. So we'll just request how Dr. Subramaniam would like to take up this case.
Good evening, Dr. Manoj, and good evening all of you, friends. The question is 63 years old female on routine checkup having a T-score -2.9 at the lumbar spine. So as a routine checkup, we need to go for the rest of the serological tests also, like how is that serum vitamin D and vitamin B12. And as a routine, I prefer to do calcium phosphorus and alkaline phosphatase and serum PTH in all these cases. We check for the vitamin D, and if there any secondary hyperparathyroidism that is a bit of higher than the normal levels of the PTH, then that goes more in favor of the low serum vitamin D levels. We correct them simultaneously. And then, as you already told that it's -2.9 at the spine, we discuss with the patient with the 2 possibilities I discuss. One is to start with bisphosphonates, oral bisphosphonates for this patient, because at the hip it is -2.1 and at the lumbar spine it's -2.9. And we give all the possible side effects of the oral bisphosphonates weekly basis. That means the possibility of the gastric ulcers and gastric irritation and a minimum take of 2 years. All these things will be discussed at length with them. And after that, in the last 1-2 years, we are offering 6 monthly subcutaneous 60 milligrams of DENOSUMAB also in these cases for the sake of convenience, and again discuss the pros and cons of using denosumab in these cases. This is how I approach this. Along with calcium supplementation, vitamin D if necessary, and observe for the serological like PTH once in 3 months or 4 months to adjust the vitamin D dosage.
So I think you've just made a very controversial remark. So I request one of the panelists to give their comments whether they want to do vitamin D PTH every 3 months in a garden variety of osteoporosis. Whatever they do in practice, see, please understand there is no right or wrong answers here. We are all sort of senior people, we've been doing. So as Ram said, the interest of should be first is that we are doing good for the patient.
Yeah, let me take up this answer. I think the question, normally what we do once it is done and once it is corrected, normally we do not repeat the reports again and again. That is one. What we concentrate on the patient compliance at our center. So that is very important. That's what we really put into the practice.
Great. Anyone, Dr. Mascarenhas?
Yeah. So
Bangalore.
absolutely. So once it is established that it is the regular postmenopausal osteoporosis, then the emphasis would be on the compliance, making sure, explaining to the patient that this is only the beginning of a big problem. And so in order to avoid that problem, we need to be putting them on oral bisphosphonates, explaining all the complications that can be there, side effects that can be there, and not to expect that it is going to change the bone density significantly in the future. We are trying to reduce the fracture risk. And then probably do a repeat bone densitometry after, say, 2 years. After 2 years, and ensure, and then get them on regular follow-ups purely for osteoporosis. What I try to do is have a weekly osteoporosis clinic where I try and put in all my patients there in that time slot so that they can we can have a focused effort towards dealing with patients with osteoporosis. Yeah. But the blood test and PTH wouldn't be repeated too often.
Yeah, I would agree with you on that. Yes, Dr. Subramanyam.
So how many panelists are routinely doing serum PTH along with the workup of the osteoporosis?
I always do it. That is the standard protocol which we follow at our center.
Yes, absolutely. I think I would do, it's a standard protocol where we have to do a PTH level and check for, in fact, make sure that even the renal profile is good, liver functions, and the entire workup for osteoporosis.
We have 2 packages of the blood test. One is the basic bone profile and second one is the advanced bone profile. In the advanced bone profile, we'll have the bone turnover markers. So that becomes an expensive cost to the patient. That's why we do not do it as a routine.
So even after
let's keep the bone turnover markers for a later period.
Yeah.
So I'm happy with the oral bisphosphonates. So last 1 or 2 questions on this point is how do we talk to our patients regarding the expected duration of treatment? You mentioned a good point that we don't do BMDs before, say, 18 to 24 months. So, but when we talk in terms of expected duration, what do we sort of discuss?
It's about, we have, can I take up the question?
Please. You've been
silent.
silent.
We have data, the word trial and the, the trials which have done on the bisphosphonates. So that tells us that bisphosphonates can be given for 5 years, even extended up to 10 years. And they were pretty safe in doing this. Now, all through there has been an increase in the BMD at spine and hip, especially at the spine, at 3 years, after which it got a plateau. So up to 5 years, it got a plateau, and then it did not further improve up to 10 years. But there was significantly decreased risk of fractures, even if the BMD had not increased. So we can safely tell them, or we can give them an option that one has to take it for 3 years to 5 years. Of course, depending on the repeat fractures and how severity the osteoporosis is, whether it's mild or severe, or, depending on that will be about the bisphosphonates. I would start this patient on bisphosphonates only because there's a mild osteoporosis, doesn't have many other complications, doesn't put itself into severity, doesn't have a fracture prior to the presentation. So bisphosphonates probably is the best bet for this patient. I would not go for denosumab and high-fi drugs.
So I think we can safely conclude that oral bisphosphonates are there to stay. For mild osteoporosis, for guidance barrier, you don't have to write it off. And for a good reason, if you start at the bottom of the ladder, then with time, you can go up the ladder to better, stronger drugs. I think that's good. So let's take the second case that I had in mind. Unfortunately, we do see a lot of these patients, comparatively younger, 56-year-old female. She's been postmenopausal for about 9 years now. As often happens, walking on the road, the surface was not very even. She slipped, she tripped, she fell down and fractured her right wrist. Whichever city she was, we have very good orthopedic surgeons. They fixed her fracture. But then what next? Because I know I'm in a group of orthopedic surgeons predominantly, so I don't want to make any politically incorrect statements. But my friends are all very good orthopedic surgeons. So what next? Would Dr. Mascarenhas like to take this up?
Yeah, surely. So very often we've seen patients in our routine practice, even in elective surgeries, we come across patients with osteoporosis. As surgeons, we have a huge advantage that we actually are able to feel the bone as we are putting the instruments. And we, even if it's a routine degenerative case, we can assess, we have an idea about whether the bone is porotic or not. So that immediately gives us a tactile sense and a reminder that yes, this patient is having osteoporosis. So we better be assessing the patient, do a complete evaluation, and confirm that there is osteoporosis. I wouldn't generally treat a patient without doing a full workup or a bone densitometry and establishing the fact so that it is easy to explain to the patient about it. And then I would start the patient on, make sure that the patient starts their treatment as soon as possible. In a immediate postoperative period may not be conducive for them to take any drug which has some side effects, like if a bisphosphonate causes fatigue and general myalgia, body pain, you don't want them to go through that discomfort immediately. But after about a couple of weeks, then we would start them on that. And based on the severity of the osteoporosis, the other options of osteoporosis treatment would be established. And specifically in terms of a patient with a fracture, we would stress on the need for mobilizing themselves so that they do not become more osteoporotic. We would encourage them to have a active lifestyle, particularly in this patient, in this example where it's an upper limb injury. Then it's easy for them to just get started with their life and not reduce their activity level, and then choose the right treatment based on the bone densitometry.
So let me ask Dr. Kariem, suppose this lady had her BMD done, which was, reasonably good, -1.9, -2 at the spine and about -1.2, -1.3 at the hip. And her biochemistry is reasonable. She's got vitamin D deficiency, as most of our patients do have it. Calcium is 8.9, phosphorus is 3.3, PTH is 74. Would there be any change in your thought process as contrast to Dr. Mascarenhas?
Possibility, yes. I would first look for if there are any other signs of osteoporosis in her. If she has a kyphosis or if she has loss of height, though this would not be at that age, but you can always consider them. If she is a diabetic, that puts her again at the higher risk. If she has some renal disease associated, if she is on medications, right, steroids and some other medications. Now, these put her into moderate to severe osteoporosis, even if her BMD is okay. Now, in such cases, if we do fracs, then we have to bring down the level of fracs, especially the fracture at hip would be around 1. So in that case, she would definitely demand treatment. But if she doesn't have all these, I'm not sure. I may err on the side and probably not give the treatment. But maybe I'll seek others' opinions.
So the other two quick 30-second comments.
Yeah, I think I would consider her as, although the reports are all negative, I would still consider that she's osteoporotic and I'll treat her osteoporosis.
Great. And the last comment.
That's an index fracture for the osteoporosis, as the rest of the two surgeons feel. We also feel that she needs a proper treatment of osteoporosis.
Exactly. So one of the important take-home points of today's meeting is that a fragility fracture is equal to osteoporosis. It doesn't matter what
That's
the
right.
BMD,
That's right.
etc., tells you.
That's right.
So
That's
please don't lose this patient, because as I'll tell you in one of my next cases, that if you miss them at this stage, then they come back to you after a few years, maybe a decade, with a more serious fracture. So this is our opportunity to catch them. Okay. This is probably directed to Dr. Dave. Bharat Bhai, 58-year-old postmenopausal pain. She was doing some Diwali cleaning visits offer done, and she ends up with low back pain, and she comes to you and an X-ray shows a old L3 fracture and a new one, L4. So how would you like to go about? You already told us about your packages. Since we are in a surgeon group, you can also tell us what next besides medical treatment. You can give us a little on surgery also.
Sure. So my take would be to rule out secondary causes of osteoporosis. Once it is ruled out, we have considered that this is primary osteoporosis and the fracture is because of the osteoporosis only. We will start treating her with the bone induction, meaning the teriparatide. And I would always use the original molecule. Let's not debate on that in this platform. Then we continue to treat her with the teriparatide. And once she has achieved at least 1.5 years of the treatment, then we will consider, that is one management, medical management. Second management would be to give her rest for a good 3 weeks, 4 weeks, keep x-raying her so that the bone collapse does not occur. And I would go to the extent of time bomb theory, that I would want your input and help in maintaining your bone height. Vertebral collapse should not occur, as you already have one silent fracture. So second collapse, which is evident now, I do not want it to collapse further and giving the deficit. So I want your compliance 100%. I'll educate the relatives as well. We will provide them the booklets as well. Once they are through 4 weeks or 5 weeks, maybe 3 weeks down the line, if patient is cooperative, we go for the second X-ray. If it has not collapsed, then we give them the corset and we mobilize them indoor activity and with the walking aid or whatever aid according to the necessary. And then once we have gone through 6 weeks, then we give them more rights of the mobilization. If she collapses and she develops neurological deficit on the course of the conservative treatment, then we treat her surgically depending upon whatever. The vertebroplasty is currently out of the window from my clinic, from Stavia Hospital, because we are treating them aggressively with teriparatide and with the rest and with all the lifestyle modification. So the rate of vertebroplasty has gone down to practically zero since last few years. This is my way of managing, or our way of managing at our hospital. Yeah, please.
So before I ask you the second question, since Ram is also there with us, let us use his expertise also. Ram, would you do the same thing or you differ?
I concur to a large extent with what Bharat Bhai has said. And one thing which I am very aggressive about is getting a serum protein electrophoresis done in all these patients. I'm making it, I know Bharat Bhai has covered it in ruling out causes of secondary osteoporosis, but I'm vocalizing it, that we need to rule out the commonest enemy that we may have and tend to miss, which is multiple myeloma. So I tend to do that very, very aggressively. And I also go to the extent of getting the light chains done and everything done to rule it out. So I'm pretty aggressive on that one point. Besides, as far as the surgical part, yes, stand-alone vertebroplasty or cement augmentation for the present is absolutely not done. But yes, there are times when we combine a little bit of cement with other forms of surgery which are needed to decompress or stabilize. But the stand-alone pain-relieving, pain-killing vertebroplasty, is a very double-edged and a dicey weapon, working against us more often than for us. So that's true.
Unlike any other chronic disease, diabetes, hypertension, cholesterol, we never talk of finite period. We say you need to take this and maybe for years or lifelong. But here we talk of a finite period. You mentioned teriparatide for a shot. So what next? Yeah. Okay, Bharat, you can continue. We lost you.
Yeah, sure. Sorry. I think I would go for the sequential therapy. In the fact, we have the piece of paper, the booklet written as well. We give it to the patient and we mention that this is sequential therapy. This is a lifelong disease. And following this, you have to continue to take this. If you don't take this, whatever money you have spent will become zero. In the fact, it may give you negativity as well. So in the fact, currently, for the DENOSUMAB, I ask them to take the pledge that you will take it for 10 years and you will not discontinue without informing me or informing us. You can knock the door and you say that now I cannot afford and we will change over to something else. So sequential therapy is must in the current osteoporosis management.
So Dr. Kariem, okay, I'll just ask Dr. Kariem and then come to you. Dr. Kariem, what is your approach in whether Srinagar or Delhi?
In such patient which has a lumbar fracture and has been started on teriparatide, probably started nicely and genuinely started because she has severe osteoporosis, has had a fracture there only, and then we have not many options. We have the anabolics and we can have the denosumab itself, because both of them can be given for severe osteoporosis. Now, if we take this teriparatide only, so we give this teriparatide for a period of 2 years. And because there is study that has shown that after stopping teriparatide, the bone loss would continue. So to prevent that, we can give an overlap with bisphosphonates. So that needs to be continued. And that will, because we give aggressive treatment to begin with. And once we come to a certain level, and then we give anti-resorptive drugs, which would prevent the further bone loss.
Great. Dr. Subramanyam, you wanted to...
Yeah. I just want to discuss with Dr. Dave. Dr. Bharat, you said sequential therapy. In this particular case, there is already one fracture of vertebra, then the new fracture occurred. How do you like giving the initial denosumab, then start along with the teriparatide? You said sequential. Instead, because denosumab is fracture neutral, we should give, in such cases, denosumab, then start the teriparatide together instead of teriparatide for 1.5 years and then sequential. How do you take this suggestion?
You're talking of combination therapy from day one.
Combination of the initial itself. That's what I'm talking about.
Yeah, I think I do not deny this. I will look at the patient's pocket, patient's compliance, and we will discuss that with the patient. So all these modifications can be tried and can be planned and can be implemented. So this will all remain the same. So it all depends. What kind of, if there is something which I would feel that this patient is going to collapse further, going to have deficit, then I'll start everything together. But if it is a fracture which looks to me naive, and I feel that, time bomb is going to work for me, then I'll start only teriparatide, because it's at the end of the day, it's patient's pocket and everything.
Because the patient is treatment naive, and we could go ahead with teriparatide or denosumab, whichever is, and then subsequently give another drugs for the maintenance.
No, the reason why I asked this question is, denosumab in the initial part itself, with even the presence of fracture, within 2 weeks, majority of the patients are relieved of the pain with the bed rest and denosumab. When the anabolics start working from the 3rd and 4th week onwards, that's what my observation in my clinical practice.
Okay, that's a good point. But let me put it to the others. So does it matter whether, suppose this lady was already on a denosumab or a bisphosphonate, and then she's fractured and then reached Dr. Dave. Would her outcomes be the same when you start teriparatide now?
No, whatever data, whatever literature supports, I think denosumab first and teriparatide afterwards, it does not give you the additive effect. So if you are starting...
So you are saying denosumab for years and then teriparatide afterwards, or just 2 weeks?
That is not something that is indicated. That is, I'm sure you also would agree to that. Yeah. So that is something which is not suggested. So you start fill the pot first with the teriparatide, and then you start denosumab in order to stop the resorption. So this is something which is indicated. If you are starting two together, additive effect, 1 + 1 = 2 is not the case. 1 + 1 is equal to maybe 1.5, maybe 1.25. That's what something which is the literature says. I have no experience or nothing at our center. We have done the study.
Yeah, so the data switch is the only good long-term trial which is there. And they talk about improvement of bone density. They are not talking of fracture risk reduction.
That's
So
right.
keep that in mind. Yeah, but when desperate conditions call for desperate measures, but as a routine, I agree with Bharat that we should go 1 and then go 2. That is probably good. And whether we're talking about the pocket or whether we're talking science right now, the sequential therapy is here to stay, and the order is important because anabolic followed by anti-resorptive is much better. Resorptive, anti-resorptive, then anabolic. It's not that it doesn't work, but there is a loss of couple of months in sort of reversing the effects on the bone cells. So that is there. I think Dr. Mascarenhas has not put in his 2 bit. Sir, you would like to add anything?
Yeah, no, I'm also of the opinion that one should do a systematic combination therapy or sequential therapy. First get in the anabolics and then let the denosumab kick in. I would keep it as a reserve. Sometimes patients come, so here there's a healed fracture and a fresh fracture. I start the teriparatide and then I will put them on the rank ligand inhibitor later on. But in the eventuality of another fracture close by, then I wouldn't hesitate. I would just start off instantly and put them on both.
Yeah. So Dr. Dave was keen to discuss a little more on denosumab, what happens after years of therapy, but I'm going to hold that for a little longer. Someone wants to talk about what are the adverse effects that we are worried about in bisphosphonates, because we mentioned the adverse effect, but we didn't go into any detail. So what are we really worried about besides the GI intolerance and aches and pains, flu-like reaction, the serious side effect? Yeah.
Yeah, we have had patients even in 1 day clinic, 3 patients who came with the atypical fracture. And particularly those patients, they are those who are the rheumatoid, and then they have been on this molecule and, they forgot even to consult the doctor and they ended up with the fracture. So this kind of scenario can be warned, can be prevented by regular follow-up, and compliance of the patient has to be monitored. So this is something, and the osteonecrosis. These are the 2 side effects, which I have seen. And it's being surfacing out more and more as we are all making, these patients' bone health conscious. And that is where, these things are going to pop up as well. Over to you.
Yes, Dr. Kariem, your take on it. The duration of
the
underlying disease.
I haven't seen such a scenario because I see most of the times rheumatoids and lupuses, and many of my patients are on treatment. But luckily, maybe they've been following me properly and I've been taking care of the calciums and the vitamin Ds and rest of the things. I haven't come across fractures, but definitely in osteoporosis patients who receive, the denosumabs or the bisphosphonates, there is an incidence of both the osteonecrosis of jaw and this atypical fracture of the femur. There is no doubt about that. And this is less seen with denosumab and more with probably bisphosphonates, which have been given over a period of time. But most of these patients had a poor dental hygiene. If we don't take care of that to begin with before starting it, unless we are pressed to start very early. So we have to take care of that. We have to convince them that we don't go for any invasive dental procedures during this period. I think we are able to ward off most of the problems of these osteonecrosis of jaw.
Okay, this was not planned. You just made a statement, so it's something clicked to me. So I'll request Dr. Mascarenhas to take up this question. You have a 38-year-old lady coming to your clinic with low backache, as is so often, and you do the investigations. Nothing very significant, except that the BMD is minus 2.8, and at the femur neck is about minus 1.4. So what would your reaction be to this? A 38-year-old female with a low backache.
Yeah, I'll go through this is a familiar scenario, and I will go through the routine tests of looking at renal functions and liver functions, vitamin Ds and all that. But basically, I refer the patient to the endocrinologist because I think these kind of patients need much more deeper analysis. And invariably, we found some interesting things like some with a little bit of hypophosphatemia with small lesions in the skeletal, secretory lesions, which are resulting in osteoporosis and so many other things. So I refer the patients to the endocrinologist, and I don't go too much into that.
Okay.
Because I think endocrinologists are better equipped in going deeper into that.
No, Ram and I have had a lot of cases like this. So let Ram take this. And from tomorrow, you don't have to refer them to endocrinology. I'll tell you the secret.
No, you go ahead and tell us the secret. Go ahead, tell us.
So, when you're discussing BMD and you're doing a course on it and you're doing troubleshooting, please remember that there are other reasons for low BMD. Osteoporosis is just one of them. And at 38 or 32, the commonest cause is vitamin D osteomalacia, secondary hyperparathyroidism, and low bone density. So you don't have to refer to endocrinologists, just check their vitamin D levels. And if they can afford a PTH, I wouldn't do PTH in all these patients, because if the calcium is low, the vitamin D is low, I know for sure the PTH is going to be high. Treat them for a couple of weeks and you'll be pleasantly surprised that at the end of 1 year, the BMD might have gone up by 10 to 15%. Normally we talk of 1 and 2%. Here it may be a huge jump. So unfortunately, I have colleagues who would treat this patient with not one, but two anti-resorptives. So please, that's the second take-home point. Don't rush. Age is a big factor. I mean, I can understand there's been one fragility fracture earlier, there's a bad family history. Then we're looking at some rare things. Please refer to a rheumatologist or an endocrinologist at that time. But I can assure you, with these random health checks that happen in most corporate hospitals,
unfortunately,
much more of these. Dr. Kariem, exactly. You want to say something about Max Hospital?
Yeah. Even if, you find everything normal and there is some sort of osteopenia or osteoporosis in this lady, you need not to treat her. There are two issues in her. One says that if she's less than 40, we need to watch for a Z-score rather than T-score, because T-score will not tell us exactly what she is having. We have to compare, we have to do a Z-score analysis. That is one thing. And that will complete, that might give us a different story. That's one. And second is, now, even if she is in ost stage, I would not, to begin with, I may not do bone DEXA in her. I would just not do bone DEXA in her, because that will put us more into trouble than anything else. But even if she has osteopenia and osteoporosis and rest of all are normal, please, we don't need to treat her, because there is no data that tells us that she's going to develop a fracture.
Yeah, please. So I think that's the final word. In young people, right. Look at the Z-score, don't look at the T-score, and don't rush into treatment. This is not like a heart failure or severe hypertension that you have to decide in the next 15 minutes. I think Ram made a very good point. I also talk to my patients and send them away very often, that you come back to me, or maybe do a video consult if you find it difficult to come. I think Dr. Dave wants to leave us for another commitment. Bharat Bhai, you want to, although this was...
I just wanted to say only one thing. Each drug has its own time to act, but my take would be, if at all somebody prescribes the DENOSUMAB, has to be followed by second dose of DENOSUMAB. We have recent days patients not continuing DENOSUMAB and getting the new fracture. So please do not do that. If at all you're prescribing, then this drug has to be continued for 3 years, 10 years, 5 years. That currently 10 years safety data is available. But afterwards, if you are discontinuing, you have to start anti-resorptive. So please make sure, I think the message, I'm sure Dr. Manoj, you would agree to that. Instead of improving the bone health, we are going to be challenged by poor bone health because of certain drugs which are prescribed loosely. This is what sorry, my word may be wrong, but this is something which I want to message and to all our, the audience as well. I'm sure your best comment on this, Dr. Manoj, please.
No, I agree with you. Once you start treatment for osteoporosis, it has to be sequential therapy, anabolic agent, followed by a bisphosphonate or denosumab, then followed by the next. Because if we start treatment at 60 and we're looking at 90, 95, We don't
have to
have
go
enough
on.
drugs to go all the way,
No,
So,
we have to go on.
And since we are at this and before Bharat Bhai leaves, someone wants to comment on the importance of drug holidays. Which drug can be given a holiday and which not?
As of now, we give only for a bisphosphonate that we give a drug holiday, 1 to 2 years of drug holiday, so that with the idea that we can avoid some atypical fractures, and we don't fill that time with any other drug. It's a complete drug holiday if that is the plan. I generally don't go into affordability part of it, but yeah, many a times because of affordability, people are not able to afford anything else, so they are on bisphosphonate for a long time.
No. When it comes to affordability, I just tell them my orthopedic colleague will charge you maybe 6 years of therapy. So it's better you take 2 years of therapy. And it generally works. Yeah, Dr. Subramanyam, you want to add something on drug holidays because you have patients who are taking long-term steroids and things like that.
True, as rightly. These kind of patients, if we start on oral bisphosphonates, maximum upper limit what we practice here is oral bisphosphonates for maximum 4 years. Then invariably after 4 years, 2 years of drug holiday, complete drug holiday. I made it a very serious practice since beginning. That's what I practice here.
I have a question.
Is not a patient. Affordability is not a problem here. Therefore, I never look into that matter. As Dr.
I have a question. So, what makes you to go for drug holiday?
Good.
What are the indicators?
So you want
What
to
will
answer
tell us?
because that was
What
my
will tell us that you would go for a drug holiday?
Sir, whether in spite of the improvement in the BMD, in the symptoms, or the presence of new symptoms in the patients, the maximum time, even after 4 years, no continuation of bisphosphonates. That's what we have learned and practicing.
No, that doesn't answer the question. We are saying the patient has improved. We're not saying he's not improved or has had a new. See, if he's had a new fracture or is worsened, that's a different story altogether.
That is gone.
Yeah, you've treated for 4-5 years. And so if the BMD scores have become reasonably good, please remember that in follow-up, actually, we should not talk of T-scores and Z-scores. We should talk of bone density. So if the bone density is improved to the tune of, say, 5-6%, if the T-score has gone above the minus 2.5 threshold, the patient is reasonably active and asymptomatic, you can give a holiday. And the best way to follow these patients is probably a 4 or 6 monthly bone turnover marker. That's one place where even if they are expensive, they are worth using.
You have to go it.
You can't do a BMD every 6 months or 1 year. You expect, you should wait. So a bone turnover marker will give you a warning if the resorption markers start rising that you need to take some action. And this is a standard of care with bisphosphonates. With teriparatide, with denosumab, there is no question of a drug holiday. Is that good? I think, okay, let's go to the next case. Dr. Mascarenhas is 71-year-old female, male, just for putting in some variety, with a fracture neck, right intertrochanteric fracture, past history of left Colles fracture. At that time was treated by our friend with a good surgical fixation, vitamin D, calcium, exercise. And now is back to us after about a decade with this fracture neck femur. So you can give us your approach, including a little surgical approach, so that our colleagues who are listening to us also find something more interesting.
Okay. No, I'm an exclusive spine surgeon. So here is the hip fracture.
Yeah.
But nevertheless, the principles of orthopedics remain the same. Early fixation and mobilization is definitely what we believe in and advocate. And that is the easier part. Avoiding the future fracture is the more difficult part. No, the common angst that people express is that, doctor, I had one fracture, now another. When is this going to end? And here I am telling them, look, you may just fracture even just below that fracture level, just below the instrumented level. And the surgery can lead to other fractures because your bone is fragile. So it's a complex problem. Yes, patient if I remember well, you said bisphosphonates. The patient has been on bisphosphonates.
No, not on treatment.
Not on treatment.
Yeah,
Okay.
he was left alone.
He was left alone. So now we revisit the whole process. We find out if it is a primary or a secondary osteoporosis. And if it is a primary osteoporosis, put them on anabolics and take it sequentially. Not to put them, I don't put them on a combination therapy from day one. It would be anabolic and a much more closer monitoring and ensuring. I would get my team to call them up and make sure that they have received the drug. Team would confirm with them as to how they're taking it, whether they're taking it at the same time every day. And even if they miss, they shouldn't discontinue it. They get back to the treatment. 1 or 2 days of missing it because of their personal commitments may be okay, but please get back. So we would really re-emphasize on the fact that they have to be very good compliance with regard to these drugs so that we will have less complications. I'm very honest with them. I say, look, I don't enjoy really operating on a same person again and again with the same problem with osteoporosis worsening, because it is not so easy, and it's very disheartening when you see that your screws are pulling out. Whatever you do, the bones are like butter, and you're not able to correct their deformities. And one problem leads to another. They can have adjacent level fractures, implant failure. So it's very important for me that the patient is compliant and the patient is on the treatment from day one.
Okay, so just to clear devil's advocate, anyone would like to start denosumab as the first line treatment in this patient? Not because this is sponsored by the denosumab.
Yeah. So if there are other, if the renal functions are poor, and if the liver functions are on the borderline, if they have if they have malignancies, generally we don't start teriparatide in patients who are having malignancies.
I mean, this is a normal garden variety, 71
Yes.
years old, no multiple
Okay.
myeloma, no malignancy.
Yeah, okay.
But
Then
I refuse to take teriparatide. Who's going to give me injection every day?
Exactly.
Yes,
I think if the patient has a concern regarding taking a prick every day and doesn't want to take a prick every day, I would definitely switch over to denosumab.
good. Dr. Subramanyam, please.
So for answering your question, if the patient is not ready to take the teriparatide, denosumab to be considered, because denosumab is fracture neutral. In these cases, even if you are not replacing or we are doing a fixation of the hip fracture, we can safely advocate denosumab in such cases. That's what I take.
Okay, so that's a good point. You know, if I had asked this question a decade ago, the answer would have been that bisphosphonates and denosumab are the best treatment available for treating these patients with hip fracture. So lumbar spine is a different story altogether. There teriparatide works the best. But about a decade ago, after that we started thinking that teriparatide also helps for hip fracture. But if you look at the original teriparatide data from Eli Lilly, they do not talk about using it for hip fractures. But now we have seen, so yes, teriparatide is a primary option, but I always believe that if the patient is not likely to follow up and take the primary option, then I go for the second option, because at least I know that he will take. Why are we not in favor of giving a zoledronic acid infusion and sending the patient home? Sir, you are muted.
There was another study where zoledronic acid was given in patients who had a fractured hip, and their events of death was decreased by nearly 28%. Now, I don't have the exact figures.
That's the Horizon study you're talking
exactly about. The Horizon study. So then zoledronic acid also is a good bet on these patients.
Yeah, and just to sort of complete that, please remember that patient is in your nursing home hospital, is a captive patient. At least if you give one injection of zoledronic acid, you're not sure whether he will come back. See, we keep talking about giving zoledronic acid every 12 months or 15 months. But really, if you follow their bone markers, it may go on for 18, 24 months also are suppressed. So, slowly, I'm not talking of fracture patients, but in your garden variety patients that you are treating, you need to get one bone marker done at 12 to 15 months and then decide whether you want to give the injection, or you can still push another few months. Because as I repeat, this is a disease where you have finite options for finite period and your patients are going to live infinite. So you always have to be conservative. It's not that my patient can afford or can't afford. We don't have treatment options. You start at 55, you'll run out by 70.
Exactly.
So just keep that also in mind, Okay.
Yeah, there's no doubt, just a comment, there's no doubt that zoledronate works. We operate on patients who have been given zoledronic acid, and we find that there is definitely an improvement in their bone strength and screw purchases. No doubt.
No, I want to make a comment here.
Yes.
In acute fractures, injection zoledronic acid should not be given. Though it may improve the strength, but it leads to non-union, especially the cancellous bone like proximal hip. So therefore, if zoledronic has to be considered, we need to consider only after a minimum of 12 weeks till the soft callus of the bone is formed.
That's a very controversial statement because I don't think that is the current teaching. Whether you use zoledronic acid or denosumab, there is no difference in terms of fracture healing and in terms of the problem of non-union or whatever the orthopedic surgeon would be worried about. I think that is pretty clear. So probably we'll keep that statement of yours for discussion later on. Let us go to you. We have not discussed any case of glucocorticoid-induced osteoporosis. So let us talk of, you said SLE you treat very often. And although you've got now steroid-sparing therapies, your patient has received 50 milligrams for the last 6 weeks and then is likely to be on tapering doses till she goes into remission. So how would you decide in terms of treatment for osteoporosis?
So let's have a case scenario. So this is a young female. So lupus, we usually bearing age. So this would be a young female, maybe or maybe not married. So less than 40. So let's have another guy who is around 70-year-old or 60-year-old who has giant cell arthritis. Now who is taking steroids, who has to take steroids for quite some time. So these two scenarios we should try to separate how we will try to adjust treatment modalities in them. No, so if all adults are using prednisolone at a dose of more than 2.5 milligrams a day for 3 months, now they demand treatment or they at least follow up. Our aim is to reduce glucocorticoid dose and duration to begin with. So we go it to minimum and try to use steroid-sparing agents. So that, as you mentioned, that we can have mycophenolate, mofetils, we have lots of medicines which we give later nowadays. But then sometimes we have to continue to give them steroids. And it's very important to give them good nutrition, which may include calcium and vitamin D, because it is shown that if given alone, it also improves the BMD. And it's very important to give them a lifestyle mix, do exercises, go for walks. This would be for both. This would be for both who are elderly and who are in the young group.
Yeah. Answer, just a minute. Rishi from OrthoTV, there is some disturbance in the online streaming. Please just have a look at it. Thank you, sir.
Yeah, sorry, please go on.
Okay. And then we'll do assessment. So first assessment I would do minimum after 6 months and then probably every 12 months later on. So if she is under 40, if she's a female, if the patient is under 40 years of age, we'll see if she has a history of osteoporotic fracture or any significant osteoporotic risk factor. If she doesn't have, we don't need to do BMD on her. Okay, but if she has, we'll do BMD testing, which would be within the 6 months, as I mentioned, of the glucocorticoid therapy, and then do a risk stratification. Now, on the other hand, if he's a male who is already elderly, is taking medicines for giant cell arthritis, We cannot wait for him. We have to do BMD and FACS on him, Within 6 months of this would again be within 6 months of glucocorticoid treatment. Now, if the BMD is low, okay, if the BMD is low, the patient does not meet the, if the BMD is normal, there is low risk, and this would usually be in the young female, then we don't need to treat her. But if the BMD is low, without any, and does not meet the moderate or high risk criteria, then we to proceed further to look for the BMDs on follow basis, which would be every 2 or 3 years or whatever. Now, on the other hand, if they have a moderate or high risk, this is shade complicated. If there's moderate or high risk, if age is less than 40, we'll do her Z-score, as I always mention. We'll do her Z-score. If it's less than -3 at hip or spine, and she's taking prednisolone of 7.5, we need to treat it. We could treat it with bisphosphonates to begin with, right? Now, if the patient is more than 40 years and there is history of osteoporotic fracture, and BMD is -2.5 at hip and FREX is high, and in this case, who's taking steroids, FREX we have to take at the lower side. So at the hip, it would take it around 1% for the hip fracture. Then we see, and the patient is taking glucocorticoid.
We seem to have lost him. Anyway, so
Think of,
yeah,
I would in the elderly people, I would think of giving a denosumab, which is equally good in treating the steroid-induced osteoporosis.
fair enough. So if there is evidence of osteoporosis, obviously we'll treat. There were 2 important points I want to make. That when you start steroids in a dose which is, say, more than 10 milligrams of equivalent of prednisolone, there is very rapid bone loss in the first 2-3 months. So there is no idea waiting for 6 months or 9 months if the projected therapy is going to go more than 2 months.
Exactly.
So we should start treatment early without looking at the bone density as a deciding factor. The fact that this is going to be equivalent of more than 7.5 milligram prednisolone per day, more than 2 months, we need to take preventive action. The other thing is, fortunately for us, steroid-induced osteoporosis, or most of the endocrine disorder-induced osteoporosis, is actually reversible when you treat the disorder. So if you feel that there is going to be a finite period of steroid use, then very often 6 to 9 months after stopping the steroids, you can even think of stopping the medical treatment of osteoporosis. I mean, that probably the rheumatologist or the endocrinologist can take care. But, unlike other conditions where we tell the patient, listen, now you need to take it for a long time, here it may be different. But the important is, don't wait for long periods to take a decision, because then you miss the bus. The initial 3, 5, or 7% loss, and then later on 1 or 2% loss. So you need to catch the initial bone loss. I think we are at the end of our cases. And Javed, if there are some burning questions, we can put it up to the panelists. Ram, you have any experience of steroid-induced compression fractures of the spine and how you would look at it while Javed looks at the questions?
Well, those that I have, which are GIOPs, I mean, most of them, I would initiate teriparatide. And as far as the medical management is concerned, and that's what I've used all my life, whatever the T-score or Z-score may be, they merit the need for teriparatide. And the other thing, which is my burning question to both of you who deal more with the medical management, is one, today, where is the place for bisphosphonates, alendronate, ibandronate, and zoledronic acid? Because these are the 3 that we have that we still use. So if you could just give us some sort of a route map, when to use what?
So if you look at the 3 bisphosphonates that you mentioned, alendronate is a good choice when you're dealing with the mild osteoporosis. You're looking at long-term treatment. And patient needs some time to think. Very often when I say the option is once a year versus once a week, no, that is a very strong medicine that you're giving me. I'm not comfortable with that. And please note that none of the guidelines, NICE, the National Osteoporosis Foundation, US, the American Rheumatology Association, says that one drug is better than the other when it comes to mild osteoporosis. As a matter of fact, the ARA is the only body which talks of GIOP to be treated with oral bisphosphonate. They're very clearly in print. The others say you have to treat. They don't say how to treat. The second part, that is ibandronate. Fortunately, it's just once a month therapy. It works reasonably well, nearly as alendronate on the spine. But when it comes to hip, then alendronate is a clear winner. So if you're dealing with an elderly who has problems at the hip also, then I would not look at ibandronate. I would look at it only if it's a little younger patient, spine issues, but hip numbers are good. Zoledronic acid is probably the best from efficacy, safety,
Compliance.
and the compliance. Because I very often use that factor when I'm choosing a treatment for patients who are unlikely to follow up with me regularly. As I said, literature says 12 months. Ian Reid says for osteopenia once in 18 months. And in Paget's disease, we use it once in a lifetime or twice in a lifetime. So, I mean, we know that this drug works for years. So this 1 year and 15 months and 18 months are very arbitrary. So that's the way I would look at using it. And denosumab is a wonderful drug, but it's not Chavanprash that you can use it for every patient who comes to you in your clinic. You have to be careful. Please remember compliance. I'm not talking of economics, but compliance is a major issue. We got caught in COVID. We went to the US to our daughter. We could not come to you for this follow-up. I tell my patients, there is no excuse on this. You have to be very clear that when I say 6 months, it could be plus minus 2 weeks, not more than that. I mean, Bharat had some cases with he wanted to discuss on the increase in fracture risk if you are defaulting on denosumab. But people like Serge Ferrari and big people, they say that it's not increased risk. It's just that the patient is going on to the old fracture trajectory that would have happened if they had not started treatment.
No, I have a very interesting take on this. In fact, I tell my patients, and I've been doing it ever since I started using denosumab, is that it's like an insurance premium you need to pay twice a year. And it makes them understand it very, very clearly. Just like they can't default on an insurance premium, they cannot default on use of denosumab. So that's what drives the point home. And I found them that they are pretty compliant and adherent to therapy. So I am pretty happy using those words.
What one can do.
Mascarenhas is in deep thought. He wants to give last words of wisdom. Yeah, you're muted. No,
Amrit, you're muted. Amrit, you're muted. Please unmute. Yeah.
I was actually thinking on how I would use the same lines in the future. Having said that, I keep emphasizing on them, and most of my patients are do follow, and I get my team to keep track of it also, so that they understand that we are serious about treating them.
Yeah.
The other issue that I have a question to ask both these the people who medically handle things better. How much are the dentists interfering with your use of denosumab? And how do you handle them? What is the clear-cut guideline? When can you say yes and when can you say no?
Dr. Kariem, you want to take that first?
As we mentioned, that in starting the either a bisphosphonate therapy or a denosumab, we need to have a good dental checkup, unless we are pressed and we don't have any time. So once we have a good dental checkup, then make sure that most of the procedures are done. If there is tooth extraction or there is some filling done, that is very important. But after that, while you are, especially if you are on zoledronic acid, and if you are on bisphosphonate, say alendronate, for alendronate, maybe you'll have to wait for 3 months for doing an invasive procedure. For zoledronic acid, you have to wait for a longer period. I mean, complete 1 year, even after that. So, and denosumab, so we give them strict directions not to do it, not to do a dental procedure unless we are asked. Now, if you have to do a simple thing like you have to do some cleaning, that can be done. That is not a big issue. But invasive procedures like a dental extraction or a root canal, these can be notorious at times.
So, from what I've read and what I follow, it is not mandatory to have a dental checkup before starting bisphosphonate. I mean, you definitely would look and ask them about their dental hygiene. But remember that most of these side effects occur in immunocompromised patients, diabetic patients, the rheumatology patients, malignancy, where you're using a very high dose of zoledronic acid. And the duration of therapy is also important. But basic care is important. See, what happened in the late 90s is there was so much of bad publicity about this ONG and atypical fractures that the treatment of osteoporosis became a big issue. I don't want to fracture, just to prevent a fracture. But that is fortunately now taken care of, and the risks outweigh the benefits far outweigh the risk. So it's definitely there. I think in the last 2 minutes, there's some 3-4 questions. We can take them, but in just one-line answers. If the patient is suffering from renal problem and patient having osteoporosis, what do you suggest?
DENOSUMAB.
For the orthopedic surgeon, refer to the physician.
I would do that.
Yeah. How much role does genetic have in osteoporosis? It's a very important question. We didn't touch on genetics. Anyone wants to take that?
See,
yeah. Please.
There is definitely, I don't know about that because I did my PhD in orthopedic genetics. That's why I'm able to tell you. But my topic is in osteoarthritis. Osteoporosis is not, I have not studied, but definitely there is a role of genetic basis in the development of the osteoporosis. For information, we are able to see today, these days, much younger people getting osteoporosis in the pediatric age group also. I think as an endocrinologist, you can do much.
Pediatric is a different thing, but yeah, one-line answer is genetics does play. And if you have a family history, especially if your mother has had a hip fracture, it is the equivalent of what we were discussing earlier about a Colles fracture or a lumbar vertebral compression. That becomes a very strong point. Okay, and very interesting question. Why are women at greater risk of osteoporosis than men? That's the $1 million question after hearing the whole Ramayana.
Yes.
So one of you can take, Dr. Kariem, you want to take it?
This is for you, sir. This is for you, sir.
Okay. No, sir. Remember one thing, when we talk in terms of prevention of osteoporosis, it's not at 70 or 60 or 50 or 40. We have to start right from childhood, where the bone mass is, getting accredited. And during puberty, during their early development, and till they're about 30, 35. So end of third decade, your bone mass increase stops. So you've reached peak bone mass. Now, why women have a lower peak bone mass than men? There are multiple reasons. One is they are shorter, they are lighter, so the bone mass is more in men. And socially, I should not be taken wrong, but the boy child probably gets a little more attention than the girl child earlier. So hopefully this will change in the next decade or so. Your girl child will also be better off. But multiple factors, then after that, pregnancy, lactation, so all these things add to bone insult. Smoking and alcohol, unfortunately, have reduced in males and picked up in the females. So all in all, the lady ends up, and after that, by the time they're 50 or perimenopausal, they go into the perimenopause and menopause and again lose bone mass, whereas men, as far as I know, don't go through a menopause. So till about 60, the female has so much of disadvantage over the male. It's only after 60 that we go into the phase of senile osteoporosis, and both males and females lose bone mass about 1 to 2% per year. So the long and short story is that by the time male and female reach 70, there is a huge gap between their bone mass and their fracture risk.
There is a thank you, sir. There's one question actually. Since it came live to me on the phone, after long-term teriparatide treatment in elderly patients, any observations of seeing soft tissue organ malignancies? Cases which was earlier was the case actually.
The simple answer is no.
Simple answer is no. Okay, sir. And can we give teriparatide for more than 2 years?
The black box warning has been improved.
Has been improved. Okay. It's actually removed.
It's
has
been
been removed.
now. Yeah,
It's been removed. And do you advocate teriparatide right now for more than 2 years? This was the question that came. Yeah.
Okay. So 30 months for GIOP.
Okay.
This was a standard DM question that if in those days the
black if was there, yes.
Would you give it for longer?
Longer.
So the interesting part of anabolics is that it works on a therapeutic window where anabolism increases, but catabolism has not caught up.
Yes.
So if you look at the P1NP at 3 months, 6 months, 9 months, even 12 months, you may see a steady increase in bone formation. After that, you don't get that much of an increase. So I'm not sure whether giving it for more than 24 months is going to make any difference, because by that time, the bone resorption has also caught up with bone formation. Okay. So, if you look at the new drugs, romosozumab or abaloparatide, they are also talking of a finite period of 12 months and 24 months. They are not talking of long periods. There was no soft tissue tumor or osteosarcoma in those patients.
Right.
Yeah, so 24 months is
24
good.
months is okay, fine. I think that's from the question. There are more, other questions, but most of them have been answered in the discussion as well. So can we wind it up, sir? Basically, yeah. Thank you so much. In fact, it was an enlightening evening. Heartfelt thanks to Ram sir, Manoj sir, Khan sir, Bharat sir, Subramanyam sir, and Amrit sir for a wonderful discussion. I'm sure those healthcare professionals who have watched this program would have carried a lot of take-home points actually. I have myself jotted down almost 14-15 points, which I can probably discuss with other doctors when I'm meeting them. But one thing from a pharmaceutical company point of view, let me share with you that osteoporosis is still a very gray area when it comes to monitoring is concerned. That's why we do not have much Indian data available as well. So what we have decided right now in our company is for some selective cases where you feel monitoring is required, we will do the P1NP as well as CTX, both bone formation as well as bone resorption marker free. We have an all India tie-up with Lal Path Labs, which will be starting from 1st of September. So you can probably give the patient details and we will not interfere with the reports. It will come directly to you. So that you could probably decide during the course of therapy whether you need to have a sequential or whether you need to switch or anything, which will just benefit in terms of probably monitoring. So that's probably from one thing from my side, which I want to share with you. So, and thank you once again for joining us, and thank you for the opportunity, and thank you for the partnership. We stand by you in terms of patient care and osteoporosis management. Thank you very much, sir.
Thank you very much. Thank you, everybody.
Thank you, everyone, sir. Thank you very much. Yeah.
Thank you.
Bharat sir, you are muted, but yeah, thank you very much, sir. Bharat sir. Yeah, he's left. Okay. Rishi, can we close it?
Yes, sir, sure. Thank you very much.
Thank you. And recording will be there, and you can later on send me the number of people who attended the program. Yeah.
Sorry, sir, I can't hear.
What I'm saying is later on you can send me the details of the viewers and everything, those who have viewed the program, and it will be there in YouTube, right?
Yes, yes. Will be already there on the
Right, right. Okay.
Facebook.
Bharat sir, if you are hearing me, the meeting has ended. Thank you very much for joining in, sir.
Sir, can I end this meeting?
Just a minute, because Bharat sir is there. I'll just give him a call and then, yeah, just give me a minute, Rishi. Yeah. Sir, good evening, sir. Sir, meeting has ended. I'm just closing it with your permission, sir. Right? Thank you, sir. Thank you. Thank you, sir. Yeah, nice. Nice, sir. Wonderful, sir. It was a very good discussion, sir. Thank you. Yeah. Okay. Yes, Rishi, I have spoken to Bharat, sir. You can close the meeting. Yeah. Kumel, any other comments? How?
No,
Phone में
sir.
बात करते हैं. Phone में
Yeah,
बात
yeah.
करते हैं. Okay.